Thank you, Barbara, for those sobering statistics, but an important reminder of where the work needs to be done. Our next speaker is going to be Christopher Recklitis, and Christopher is going to be talking about these similar kinds of challenges, but from the perspective of individuals who are diagnosed as children and adolescents. He joins us from the Dana-Farber. Thank you, Christopher.
Thank you very much. I want to thank the organizers for inviting me and giving me opportunity to talk about young adult survivors or adult survivors of childhood cancer. I gave this talk the sort of title Life After Cure, and that can help us sort of shift the focus a little bit or make the focus on this group, because most of these patients are going to expect to be cured. Pediatric cancer patients, a very large proportion, will be cured by their treatment, and because of their age and the curative treatments, they will live for a very long time with late effects. And so I'm really going to focus, if I can get those slides to go, I'm really going to focus on long-term survivors and people who are years after their treatment. So in terms of what I hope to do with my time today is to summarize briefly what we know about the prevalence of psychological late effects in this group. I want to talk a little bit about the severity and the kind of impairment we might see and the risk factors, and kind of create sort of a portrait of what this population of survivors looks like. And then in the last few minutes, I hope to talk a little bit about what, with that portrait in mind, what the implications are for what services they're going to need and how we as behavioral health care providers are going to need to provide that and the systems that we're going to need to support that care. So to summarize the psychological late effects, because as Dr. Anderson said, this is a very large literature. I'm going to rely on large cohort studies, and primarily I'm going to talk about results from the Childhood Cancer Survivor Study, which many people know is a multi-center study. It is of 5-year survivors or more. So again, these people are far past their treatment. In the CCSS, we have self-report psychological outcomes and quality of life outcomes in more than 7,000 adults. And we have parent report on several thousand children. And we have comparative data, which is very important, on sibling controls. So if we look at the big picture in terms of adult survivors in the Childhood Cancer Survivor Study, we do see some very concerning statistics. We see that these folks are twice as likely to report significant psychological symptoms compared to their siblings, particularly symptoms of anxiety and depression. We also see that they're almost twice as likely to report suicide ideation and almost twice as likely to report that mental health, they have a significant mental health impairment. We also see that they're dramatically at greater risk for reporting symptoms of post-traumatic stress. When we look at the adolescent survivors, so these are still the people under 18, we also see similar picture. Parents are reporting that these kids, compared to their siblings, are showing more externalizing problems as well as more internalizing problems, which would be things like anxiety and depression. And we see this in studies kind of regardless of diagnosis or regardless of treatment. It's fairly robust across the subgroups of the CCSS. I also want to talk not just about psychological symptoms, but social attainment, because as we talk a little bit more about developmental effects in this cohort, those two things are tied closely together. We see in our childhood cancer survivors as they grow up, they are more likely to report impaired quality of life. Also, they're more likely to require special education services, more likely to have unemployment and unemployment due to health, and they are somewhat less likely to marry than their siblings. Up until this point, I've been summarizing from the Childhood Cancer Survivor Study, but I just want to point out it's not only within the CCS we find these things. These results that I've been summarizing for you are similar to what's been reported in other large cohort studies of adult survivors of childhood cancer, which have shown educational impairments, social attainment limitations, and also increased psychological distress. So to summarize this sort of very rapid tour of psychological late effects, we can see that childhood cancer survivors are at increased risk for psychological symptoms, and I underscore that because I'm going to talk about that that's not the whole story. We'll see in a couple of slides. And we see that they have impairments in education, work, quality of life outcomes. What we also have to appreciate is that most survivors are adapting well. So that even though as a population they are at greater risk, it is not a population that is overwhelmingly having psychological distress or problems. Maybe 60 to 75% of these childhood cancer survivors are not having problems. The vast majority do marry and find employment, even though they may have some lags or limitations there. Almost half, when they're asked, report that cancer really had little impact on them in their adult life, which is interesting. And many do also report positive consequences of their cancer. So it's important to keep a balanced view. I think the other thing that's very important when we look at the CCSS literature and other literature is to remember that symptom scales are not telling the whole story. So someone may say, yes, I saw a patient in clinic last week who tells me she has panic attacks once a month, and I roll up my clinician sleeves and I'm going to do a DSM evaluation. And she says, yeah, they don't really bother me at all. I don't avoid them. They come, they go. It's no big deal. I don't want any treatment. And I kind of take a breath, and I'm not quite sure what to do. She doesn't have a panic disorder. She has panic attacks. She doesn't have a diagnosis. She doesn't really want any treatment. That may not be common, but it's also not extremely rare either. We know from adult survivor studies, studies of adult onset cancers, that many adult cancer survivors have symptoms without necessarily having a diagnosis. And although there's some evidence of increased mental health or major mental health problems in childhood cancer survivors, it's pretty limited to brain tumor survivors, where understandably neuropsychiatric and neurological issues are at play. So I think most people in this field would agree that most childhood cancer survivors with symptoms don't necessarily have a psychiatric diagnosis. And that's going to be important when we think about treatment. I'll show you a little bit of data my colleagues and I published recently. We had a small cohort, 247 survivors. These were young adults. We gave them a diagnostic interview, and we looked at whether or not they reported sort of sentinel symptoms that would require going on with the diagnostic interview, and whether or not they actually had a diagnosis. And we saw that we had about 40% had these sort of sentinel symptoms that would require more of a SCID interview, but fewer than half of those actually ended up having a diagnosis. So where 40% had symptoms, only 18% actually had a diagnosis. And I think that's pretty common in the literature, and also clinically is similar to what we see. So if we want to think sort of conceptually about childhood cancer survivors, we can think about this sort of stratification model people have talked about. If this is sort of the normal population of just people in America walking around, most people, many people are sort of at low distress or low impairment. There's a modest group that maybe has a little bit more anxiety, depression, things going on. And then there's a small group at the top who are in the clinical range who probably have a psychiatric diagnosis. You could imagine that if you expose a population like that to cancer or childhood cancer, you could get a picture like this, where you have an explosion of the yellow and pink. You have a lot of people at moderate and high distress, but that's not really what the data show. What the data in our clinical experience suggests is that low distress probably gets a little smaller, the moderate distress and impairment gets a little bigger, and the pink, the high distress, is probably not all that different from the normal population. And we'll talk again, if I give myself time at the end, about the implications of that. I want to mention a couple of risk factors that are very important in terms of understanding psychological late effects. And the major one is medical late effects. So all the major medical late effects of childhood cancer, overall health, pain, disfigurement, chronic conditions, they are all consistently, strongly associated with poor psychosocial outcomes of all kinds. The other issue that I want to mention is that those childhood cancer survivors who are treated with CNS-directed therapy, therapy to their central nervous system, and particularly brain tumor survivors, do worse, again, for a variety of reasons, but often because of neuropsychological and neuropsychiatric problems that they are at higher risk for because of their treatment. I'm going to sort of skip that slide and just say, I think conceptually we can think of those physical late effects maybe as sort of a final common pathway, in a way that you get diagnosed with cancer as a child, you get certain treatments, that leads to some physical late effects potentially, and those have significant implications for your later emotional health. There's also that functional piece. If you have certain symptoms, you have trouble with sort of psychosocial attainment, driving a car, having a relationship, going to college. Those things are, outcomes of concern of their own, and they also have impact on emotional health as well. So I also want to make the point, I don't think it's a tough sell, is that when cancer onset sort of predates attainment of adult capacities and roles, the impact on those roles is going to be much greater. And I'll try and give you a quick illustration. This is a young man, similar illustration of a young man who came to our center a few years ago. He had osteosarcoma as a teenager. He had had many, many problems with his bone graft. He'd had many, many surgeries. And we were seeing him at age 20 when he was told he was going to need a big surgery and a whole new graft. So he was a mess, understandably. He had medical late effects, he had emotional late effects, he had schoolwork and financial problems because he had missed so much of his normal development, and he had a lot of social problems as well. You can almost sort of see that cascade of medical late effects into the other domains of this young man's life, and it's not hard to see how those medical effects would be impacting him very broadly. The other piece about the developmental piece for young adults is to realize that their symptoms are going to perhaps wax and wane depending on other things going on in their lives so they're going to have sort of vulnerable periods. Some of those around life transitions with a new diagnosis, like our patient John. Some of them moves to a new environment, new relationships, career changes. The symptoms may come and go in relationship to what's happening in their environment. So thinking about that picture, I want to try and take a few minutes and talk about what kind of services these folks are going to need and how are we going to try to implement them. Not just spoiler alert, I don't have a lot of answers, I have a lot of questions. So what challenges do we need to be prepared for? Well, we said about 20 to 40% of these people are going to have needs. Symptoms are going to be really across the spectrum, but a lot of mild and moderate and fewer people in the severe range. There are going to be a lot of different problems or areas that we might want to look at. We may need to be thinking about people having episodic presentation, so they look okay one year, but they don't look okay the next year. We clearly need to be thinking about the impact of physical health on mental health in order to help these folks effectively. And we need to be thinking of the disruptive effects of cancer on their development. I should just end there. No. So there are many, many challenges. I'm obviously not going to talk about all of these, but some of these are going to be talked about later today and tomorrow. I'm going to pick out a couple of technical challenges to talk about appropriate interventions and identifying people in need, and also touch on the last piece, conceptually, what kind of model of care could possibly work for these people. So one thing we need to think about in all of this is, where is the treatment going to happen? Sometimes the cancer center or the cancer clinic is the optimal place for care. People are coming for follow-up. We understand their treatment and late effects. They trust us. We're integrated with the medical care. But sometimes we are not the right place. And I work in a survivorship center in a cancer center, and I'm sometimes not the right person or the right place to be doing the care. I may lack expertise. I saw a patient in our clinic a few months ago and diagnosed him for the first time with OCD. Well, I haven't treated a patient for OCD in 20 years. Like, I am not the person to do that treatment. He actually lived hours away from the cancer center, so that's another barrier to care. Sometimes having everything at the cancer center plays into some denial or resistance, that there are emotional health problems that need to be dealt with. And I think sometimes it maintains dependence. These are young people. They need to get out in the world. They need new friends and new doctors and new therapists and learn how to make new relationships and not come back and have everything where they understandably feel most comfortable. So if we think about what we're going to do, we can go back to this sort of stratified model and think about these people who are at the low distress, or what Ann Kazak would call sort of universal care. We don't need a lot of triage for these people because it is universal care. We're going to give this to everyone, so we don't need to do a lot of screening. This is going to be stuff we're good at doing at the cancer center because it's about education. What happens after cancer? What kinds of monitoring do you need? What kind of self-help and support resources are there? I think much of this may be comprehended in care planning if we do it right. We could give a lot of this information to people in the survivorship care planning context. Although clearly there are going to be challenges in terms of having enough programs and people and having this delivery be consistent across different groups and geographically. But this is probably a kind of build out of existing care and good survivorship care that people are talking about already. At the other end of the spectrum, we have these people with major mental illness, and like my patient with OCD, we're probably not going to do that at the cancer center. These folks are going to need professional, expert care at dealing with mental illness. Our role as behavioral health people connected to cancer centers or cancer clinics is going to be to get referrals, to educate providers, to maybe be a liaison or help with case management. But the basis of this care is not going to be in a survivorship clinic. And again, triage and screening and assessment may not be a big part of this. These are fairly rare disorders, and they kind of declare themselves. Someone has OCD, someone has bipolar disorder. Eventually, it's going to come out probably sooner rather than later. And that brings us to the middle box, which is the most complex. Because here we have a range of people with kind of a range of different symptoms. They're going to need all that routine care I mentioned before for the people in blue, but they're also going to need more triage and targeted care. They're going to need more evaluation, they're going to need symptom-related care, they're going to need programs maybe at the cancer center or at a cancer clinic, as well as in the community. We're going to need to triage these people because they have a range of symptoms, and we don't necessarily know their impairment or whether they have a diagnosis or not. We're also going to be able to need to differentiate these symptoms from their medical late effects. They have cardiac conditions and neurological conditions, and they take lots of medicines. So we're going to need to do this in a really thoughtful way. We're going to identify, someone said earlier, I think it was Darcy, ask in a lot of different ways. We're going to have to ask in a lot of different ways, in person, on rating forms, on history forms. Screening forms, I think, are going to be helpful, but it's easy to over-evaluate them. My colleagues and I have published some data recently that standard screening scales may miss 20 to 40% of our young survivors who actually do have a psychiatric diagnosis. So clearly we're going to need to improve these measures or use them more thoughtfully and not just rely on them alone to do the evaluation. For this middle box, we're going to need a range of interventions. We're going to need low intensity and high intensity interventions. Probably stepped care models are going to be ideal. We're going to need a whole range of foci of what those programs are going to involve: social, mental health, a lot of biopsychosocial things that have been mentioned: sleep, fatigue, sexuality, that have physical aspects but also have psychological aspects as well. We're also going to need to work to understand the commonly observed modest uptake. Even when we have programs available, survivors don't always come, and we don't really know why. Whether they're busy, they're healthier, they're doing other things, doesn't fit in with their schedule, or whether we need to do a better job delivering those in ways that are attractive. So if we think about our patient John and these different effects, clearly to do a good job for him, we're going to need, behavioral health is going to need to be integrated into the survivorship setting, and we're going to need to be coordinated with outside providers. And that's a tough call, but there are some models, one of which I'll touch on here, which is the primary care behavioral health model. This model is really tried to address in primary care what I'm saying we need to do in survivorship care, which is early identification, quick resolution, problem prevention, and wellness promotion. I think we can borrow a lot from these models and learn a lot from these models in terms of survivorship. But we're going to need to do things differently. That's one of the things we don't talk about, integrated care. When you integrate care, you have to stop what you used to do and start doing something new. So as a behavioral health provider, I will have to actually be working in a medical clinic, not in my nice office. I'll actually have to go to the conferences with the oncologist. I'll have to see patients the day they're seeing them, maybe the hour they're seeing them, maybe in the exam room. All of these things that primary care behavioral health care providers do, I will need to do in order to make this work. These are some of the things I think that we need to do as behavioral health care providers, is support medical providers in their role as identifying and helping survivors with mental health or emotional health issues. We may offer some co-management, and we also try to resolve some problems in the survivorship setting, but also refer out to specialty settings or to the community. I'll look at these really quickly. So the model that I'm advocating is really a model I practice with Larissa and others at the Dana-Farber. Is the medical providers are the frontline identifiers of problems. We help them figure out what screening measures they might want to use and how to interpret them. But they're the front line. We provide consultation, maybe in real time at the clinic, either to the physician or to the patient. And we also provide backup services when needed. There's a range of interventions one may provide in the primary care behavioral health model. One of the things I like about this model is not every setting is going to have everything that every other setting has. Some settings that are smaller, have fewer resources, might just do assessment and referral of survivors, if that's all you can do. Some might do some assessment and education, but not do supportive care and limited treatment, depending on what resources are available and the patient population that's being treated. It also may depend on what's in the community. If you have great, we are in Boston. We are down the street from a wonderful anxiety treatment center. So I would probably treat more anxiety if I weren't down the street from that center. I think consultation education obviously is going to be very important. Some of that is sort of normalizing, doing anticipatory guidance. I think educational programs are very important, especially if you think about young adult survivors. There's a lot of education as people get older. They don't remember their cancer or their diagnosis. They have new medical late effects coming on board or being exposed to. So talking about things like sexual health, sleep, fatigue, having short programs that they might come and take a taste of before they're willing to actually get treatment for can be very helpful. If we do treatment in the survivorship setting, I think it's going to be brief. It's going to be a limited number of encounters, and we're really going to focus on the issues that we should be focusing on in a survivorship setting, and that's going to be medical challenges, like our patient John, who's coming back for a big surgery. It doesn't make sense for you to send him out to a community therapist to do that. I'm the one who knows the surgery, and I'm the one who can talk to his oncologist. We can work on that together temporarily. And when the surgery's over, I can help them find a therapist in the community. One of the things I think that's important is to resist the call to provide all care to all survivors. We don't have to do everything in the survivorship setting. We're not bad people if we refer them out. We're not failing them. We're failing them if we neglect them. We're failing them if we don't make referrals. We make bad referrals. We don't follow up to see if they took referral. That is bad care. But saying to someone, you have an anxiety disorder, let me educate you, let me refer you, let me call you next week and see that you've actually done that, or let me ask the facilitator in the clinic to call you. That can be good care. And I think sometimes trying to do everything gets in the way of us trying to do what we actually can do. So, of course, this slide speaks to that, sort of referring people out to what's in the community. Sometimes community services are wonderful. Sometimes we need to do some educating of outside providers on cancer late effects. Sometimes they underestimate and they don't realize the late effects are affecting mental health. Sometimes they overestimate, and I sometimes send patients with a lot of long, psychological, psychiatric histories, and outside providers will think, oh goodness, I didn't know this is what happened to cancer patients. You think, no, this isn't typical. These kinds of problems are atypical and may not be related to the cancer. So that can be an important role. So obviously, as we move towards integrated care, there are a lot of challenges and a lot of questions. The point I want to make in closing is I think there are existing integrated care models, and I think they can be adapted to help us figure out how to provide behavioral health care to adult survivors and young adult survivors of childhood cancer. I've talked about primary care, behavioral health. Other people have mentioned other models. There's a lot here, I think, for us to mine as we look towards the future.